Good evening, everybody, and welcome to the interventional meeting organized by Wincars Association. Today, we have on our esteemed chairpersons, Dr. Sujata Viparla, who's Director Cardiology from Indus Hospitals, Visakhapatnam. We have Dr. Tripti Dev with us, who's Senior Interventional Cardiologist from Apollo Hospital, Hyderabad. And we also have chairing the session, Dr. Sridevi, who's Professor of Cardiology at Dr. D.Y. Patil Medical College and Hospital, Pune. We also have an esteemed panel with us, comprising of Dr. Cecily Mary Magella. She's from Chennai, Professor, Department of Cardiology. Dr. Ritu Bhatia, who's Senior Intervention Cardiologist from N.M. Wadia Institute of Cardiology, Pune, and Dr. Ruchi Gupta, who's Director Cardiology at Sri Kalia Hospital, Jaipur. Without any further delay, we will go to our first speaker of the evening, Dr. Seema Ajay Naxane, who is Consultant Intervention Cardiologist at Premier Heart and Kidney Care Clinic at Nashik, and she's going to be speaking about a very interesting topic. So she's going to be speaking about left main bifurcation stenting with elective two-stent strategy by mini crush technique. Dr. Seema, over to you. Please share your screen.
Thank you, madam. Yeah. Is my screen visible now?
Yes, your screen is visible. Can you go to slideshow?
Yeah. Yeah. So I'll start with my case. My patient, I'll minimize this. Yeah. My patient, a 79-year-old gentleman, is a known case of hypertension, dyslipidemia. He had history of transient ischemic attack in 2013, and he's also a known case of Parkinsonism on treatment. He presented to us with a history of chest pains in 6 to 7 days. ECG-wise, it was evolved anterior wall MI plus inferior wall MI. I will show you the ECG shortly. And echo-wise, there was regional wall motion abnormality in both the LAD as well as circumflex territory with an LV ejection fraction of 30%. Yeah, so this was his presentation ECG. You can see evolved anterior wall MI, as well as there were these ST elevations in the inferior leads. You can say that lead 2 ST elevation in lead 2 slightly more than lead 3, and 1 and AVL do not show proper reciprocal ST depressions. Yeah, so we took him for coronary angiography. I'll share the loops with you. His right coronary angiography was a non-obstructive disease. This is his left system. This is the areocaudal view, which shows that there is some distal left main disease, around 50%. There is an proximal LAD, which is quite critical. Then this spider view demonstrates that even the circumflex ostium seems to be involved. Yeah, this is the epicranial view, where it seems that probably it's only a LAD disease. However, yeah, this is the epicaudal 45 angular degree. This view clarified the things for us. In this view, you can clearly see that the distal left main is 50% stenosis. The osteoproximal LAD is critical. And here we can see that even the circumflex ostium is involved with at least 60 to 70% stenosis, and it is hazy also. Sorry. Yeah. So this is the still frame of the same. You can see the distal left main involvement, and this is the systolic picture of the circumflex ostium, and this is the diastolic picture. So I was sure here that this is a true distal left main bifurcation with involvement of, it's a Medina 111 with involvement of the side branch, a significant, and the side branch disease is, yes, it's not very critical, but it is at least 70%, and the ostium looked hazy to me. So now here we can have a discussion and debate as to how to tackle this distal left main bifurcation, provisional single stent strategy versus selective two stent strategy. Now, as I already told, it's a Medina 111 with a hazy lesion, around 70% at the circumflex ostium. Now, this patient had severe LV systolic dysfunction with regional wall motion abnormalities in both the territories. And in his case, I had no mechanical circulatory support available. There were financial constraints. Even imaging was not feasible because in our lab, imaging is not immediately available. You need to arrange the imaging, as well as his insurance policy had some financial limitations. And in his case, because of severe LV systolic dysfunction and hazeosteum, I wanted to secure both the branches. And I thought that I cannot afford any hemodynamic instability, which might be created by an acute side branch compromise. Hence, here I opted for an elective two-stent strategy. We know these are the definition criteria to define a complex coronary bifurcation lesion. These were, we know that there are two major criteria. In case of left main, the side branch lesion should be at least 70% or more, and the side branch lesion length should be at least 10 millimeter. In my case, the lesion is around 70%. However, the lesion length was not more than 10 millimeter. Also, there are minor criteria. More than mild calcification, multiple lesion and all. The anatomy of my patient does not really is defined by this complex coronary bifurcation definition criteria. However, considering the clinical scenario and the practical consideration, I still decided to go ahead with the elective two-stent strategy. Now, once we have decided for an elective two-stent strategy, which technique of bifurcation should be used? In this case, the left main, there was quite a discrepancy between the left main and the side branches side. So culot was out of question. Amongst the crush techniques, DK crush is a class 2B indication as per ESC guidelines based on DK crush 5 and definition 2 trial. However, I think while doing any DK crush case, you must know all the nuances and the minute details. Otherwise, it's very difficult. DK crush is called no pain, no gain. After finishing my case, I have few slides in which I'm going to discuss about DK crush versus mini crush. So while doing DK crush, you have too many steps, more hardware usage, more radiation exposure, more contrast. It's a prolonged process. So I decided to go with a mini crush. Yeah, so we wired with the vessels. Then we pre-dilated the LAD. We pre-dilated the side branch also. Yeah. After that, I have taken a 3O by 12 millimeters Heinz Sierra stent in the circumflex. And I have put a 3O by 15 millimeter balloon in the LAD. Actually, the procedure was done through radial route and it was a 6 French guide. So I have done not the classic mini crush with a 7 French guide, but a step crush or a balloon step crush. So this is how the side branch stent was protruding in the main vessel by 2 to 3 millimeter. The stent was deployed. Yeah. After deploying the stent, we just took a check shoot to see there is no distal edge dissection or the side branch is flowing well. After confirming this, we removed the side branch stent as well, wire as well as balloon. After this, I have crushed the side branch stent with that 3 by 15 millimeter balloon. And after crushing the side branch stent, then I took a 3.5 by 33 millimeters Heinz Sierra in the main vessel. Yeah, now this is where I deployed the main vessel stent. This is the picture after deploying the main vessel stent. Now, after this, before recrossing, I did a pot. Now, pot was performed by a 4O by 8 millimeter balloon. This is the performance of pot before recrossing. Yeah. Now, this is after a performance of pot. And then the side branch was recrossed. Now, ideally in the crush techniques, the crossing should be through the proximal stent strut as opposed to the distal crossing advised in the provisional stent strategy or in the QLOT. However, here I had no means to really assess which crossing is this, proximal or mostly it is probably distal, but the recommended one is a proximal cross. Now after this, sequentially, we passed a 1.5 by 8 millimeter balloon, followed by dilatation with a 2O12 balloon. We were sure that we have crossed it successfully and we had access to the side branch. Then we completed our stenting in the distal. After deploying the proximal stent, we thought that there was a significant lesion in the mid also. So we completed that stenting. We stented mid LED with a 2.75 by 33 millimeters iron Sierra. After that, we optimized that mid and proximal LED stent. This was just after implantation of the mid LED stent. Then we optimized it with a clear balloon. And the LED stent was also optimized with a 3.5 balloon. And in the osteoproximal region, I optimized the LED stent with a 4 NC balloon. Now, after optimizing the LED stent, most importantly, before performing the final kissing balloon inflation, I optimized my side branch stent. I post-dilated it with a 3.5 by 12 millimeter NC balloon at 22 atmosphere. And then once I was done with optimizing both the branches, then I did the final kissing balloon inflation with a 3.5 by 12 balloon in the circumflex and a 4 by 8 millimeter balloon in the LED. Yeah, after this, I decided to go ahead with the pot. I used a 4.5 by 8 millimeter balloon for doing pot with appropriate placement, careful placement of the balloon at just at the carina, the distal marker. It's just at the carina. And this is the final result that we could achieve. Yeah. So the purpose of presenting this case was just to demonstrate a step-by-step demonstration of mini crush, and also to discuss DK crush versus mini crush. Now, while doing DK crush, the steps are too many, and you have to remember that when you crush in the, after deploying the side branch stent, when you crush the side branch stent, you have to do a sequential balloon crush. First crush with a balloon size to the distal reference diameter of the main vessel, and then the proximal another balloon with the diameter reference to the proximal main vessel. Okay, I'll show you why it is important, why that sequential balloon crush is so important. You can see here, this is the first balloon crush with the distal reference. That doesn't produce a complete crushing of the stent. Then when you do the balloon crush with the proximal reference, then your stent is completely crushed. And this is the picture from that weight model, where you can see that how the stent is incompletely crushed if you do only single crush with the different distal reference balloon diameter, and only the stent is completely crushed only when you do a sequential crush. So if you don't do this, and if you start recrossing here, there are multiple possibilities. This wire can go from here, anything, and can produce complications. Okay. Also, I'll just go another point to remember that while recrossing in a crush stenting, you have to cross through the proximal stent strut. Why? That also I will show. This is a very nice why proximal crossing is important. Whenever you crush a stent, okay, always a gap is created at the carina between the side branch vessel and the crushed stent. So if you do in this diagram, it is very nicely explained that if you land up crossing through the distal strut and when you inflate, there is actually a gap created. So proximal crossing is also very important. Okay, now in mini crush, I will present this evolute crush registry. I will say that DK crush versus that mini crush have never been compared with each other head to head in any randomized control trial. DK crush was compared only with classic crush in DK crush 1 trial. Now the chances of failure to recross in classic crush were in the range of 20 to 25%, but whereas in mini crush, if you do the protrusion quite minimal, protrusion of the side branch stent into the main vessel is not too much, then the chances of failure to recross are in the range of 2 to 5%. And in mini crush also, they say that there is a concept of one-step final kissing balloon inflation versus two-step final kissing balloon inflation. One step means the usual thing, you simultaneously inflate both side branch and main branch balloon at 12 to 14 atmosphere. However, what is a two-step final kissing balloon inflation? You inflate the side branch balloon first and then the main branch. There are two variations of the two-step final kissing inflation. In one variation, they say that you do individually side branch, high pressure inflation more than 20 atmospheres and main branch, and then you do simultaneous. And in another variation, they say that you inflate the side branch balloon at a high pressure, then you deflate it back to 4 atmosphere, then you inflate the main vessel both at 12 to 14 atmosphere. So this is also a micro CT study which shows that if you do a two-step final kissing balloon inflation, this stent, there is more stent strut clearance from the side branch in mini crush technique. And finally, I'm going to present this Evolute Crush registry, which was published in November 2023 in American Journal of Cardiology. It is the first study to compare cardiovascular outcomes after mini crush versus decay crush stenting in the complex bifurcation lesion. And they concluded, they have studied some 269 consecutive patients with complex bifurcation. And they concluded that the number of balloons used, guide wires used, fluoroscopy time, and the procedure time were significantly higher in decay crush group. However, the rate of composite target lesion failure was similar in both the groups. And both groups had similar rate of cardiac death, all-cause death, target vessel-related MI, or clinically driven target lesion revascularization, and even stent thrombosis. So cardiovascular outcomes, hard endpoints were similar between the two groups. So both techniques are, I think, equally effective. And rather, mini crush, if performed properly, then it is at least as good as decay crush, if not superior. And I think this is the final the summary of how to tackle a bifurcation lesion. If it's a non-true bifurcation, of course, you have to do a single provisional stent strategy. And if it's a true bifurcation, you have to decide by definition criteria, simple versus complex bifurcation. And if it is a complex bifurcation, then definitely an upfront two-stent strategy has been shown to result in better cardiovascular outcomes as per definition two trial. And in my case also, I wanted to highlight practical cases in a peripheral center in two-tier cities where we don't have mechanical circulatory support, financial constraints are there, imaging is also not immediately available. So I think in such cases, sometimes we have to proceed without imaging. Distal left main bifurcation imaging is definitely indicated as per guidelines. However, sometimes we have to even do without imaging. In those cases, I think what we try to keep in mind, not to undersize, do appropriate side branch stent, high pressure post dilatation, and never to forget the report, and do just appropriate sizing. So that's it. I think now I'm open to questions.
Wonderful presentation, Dr. Seema, and very elegantly done case. And also all the nuances which you mentioned regarding decay crush versus mini crush. It's very well taken. I myself am very fond of the mini crush procedure. I always find it to be less time consuming and typically very similar results and less time in the lab, less times of recross. So I think mini crush is a wonderful procedure, especially when you want to keep it fast. Usually these patients are typically sicker patients and you can go quite fast in mini crush. And the way that you've shown the sequential dilatation, that is also very interesting. And also the images from the Visible Heart Lab at Minnesota. Again, how it shows that you have to do a proper crush before you recross. Very great learning points in your case. The house is now open to the chairpersons and to the panelists. We'll take comments, questions one by one. We'll start with the Dr. Tripti Dev. She's the most senior here. Madam, please.
I'm so happy and so, enlightened with this case, Seema. Really, you have done wonderful case and at a small center with a lot of constraints. I was thinking if I was there in your place, what I could have done in your place. I was thinking when you have shown all the nice views, pictures and all about the left main bifurcation, I didn't see very critical lesion at the bifurcation and the length of the lesion and the angle of the lesion.
Yeah.
I was thinking I would spare that and do a FFR if I have a possibility of doing it, and which is, I think, commonly available with all of us, and that is actually 2A indication for FFR. And
Okay.
then if I find FFR is more than 0.8, which is indicated, and there is no distal lesion in the circumflex, so I could have easily gone with a single stent strategy
Yes.
and made the day with the minimum possible injury to the left main bifurcation,
Yes.
and could have got a better result. Better no, but of
Ah.
course, means
Yes, ma'am.
probably.
Yes, ma'am. I agree. In my case, the circumflex lesion length was also less than 10 millimeter. The lesion was also not too critical. The only point was that he was having severe LV dysfunction and he was having changes in both the territories.
Yes.
And I just thought somehow that he's such a severe LV dysfunction. Ostium is hazy.
Yeah.
What if the circumflex gets compromised? So it was, actually, my case falls into simple bifurcation, and many operators probably would go ahead with the provisional stenting strategy. But somehow in this case, practically, I thought there at the site, I felt that I need to secure both the branches and I cannot afford, considering severe LV dysfunction. I thought that the acute compromise may not be well tolerated. So I chose. But yes, any operator going ahead with provisional is absolutely right at his place, actually.
No, it's a wonderful case, and we must congratulate you for
Thank you.
doing such
I
a
think
nice case.
the situation in which the operator performs the case, that is most important. A patient was typically sick, severe LV dysfunction upfront. Her thought process, I believe, at that point was that if this patient, the circ has an acute occlusion when she stents from left main to LAD, it would probably lead to on-table compromise.
Yeah.
And maybe the patient could not be resuscitated because she didn't have MCS at her center. She didn't have imaging, and it was a resource constrained setting. So she chose the easier way to go in, the safer way, not the easier, because mini crush is also a demanding procedure, but she chose the safer way. So I understand that, but Dr. Tripti Dey's point is also very valid, that because the circumflex ostium, even though it looked hazy, but we could have got away with it also, because it was a very intermediate kind of a lesion. Dr. Sujata, your comments.
See, I totally agree. It was very well done, Seema. Very well, very well done. But I'm pretty concerned about the metal burden. You know, the proximal stent, distally you placed another long stent, another 312. And also you notice that there is a bifurcation, there is an OM and a circumflex, and you're putting a stent there. See, the provisional stenting is not that you're saying that you will not stent again. It is the philosophy. That's what the EBC says. You will put the second stent when necessary.
Yeah.
So even in a 1-1-1 lesion, the stenting in EBC main is 21%, 25%, 1 in 4 needed the second stent. So I was pretty concerned why you put another long stent in the, there could be just a plaque shift. As far as possible, don't put so much metal.
Right. Actually, ma'am, that mid LAD, after putting that proximal stent, when we took I could not include that shoot. The stent somehow at the distal edge there was a haziness, and it seemed that there is probably some dissection, so we covered it.
Yeah, and nowadays
because of that
dissections, if they are not flow limiting, avoid them. As far as possible, put as less stents as possible. Okay.
Yes,
Okay.
Yes, ma'am. Definitely.
That comes with time. The confidence that which dissection you can leave and which dissection you can't, especially since imaging was not there.
Yeah.
But, we like to the point that avoid as much metal as you can in the coronary is a very well taken point. So the less is better when you're dealing with the coronaries, because all the problems of metal there, chances of stent thrombosis, restenosis, dual antiplatelet therapy for quite some time, all those things which we come across. I think our third chairperson, Dr. Sridevi, has been unable to join. So we'll move to our panelist, Dr. Majella.
Yes, Dr. Seema, that was a great case and well done. Just as Sujata ma'am said, I would also try to avoid as much as metal at the bifurcation level, especially in this case where we don't have the imaging and we do not know where we are crossing, all those things. And definitely, there is a recent article in JAC 2024 July published by Hyun Jo. So I'd just like to comment here is that in complex bifurcation lesions like this, okay, we are taking, okay, it could be 50% or 70%, but we have a chance of further worsening the L6 ostium. So it's pretty good. Keep the wire inside. But what about a drug-coated balloon, if necessary, into the L6 ostium, where we do not have the image? I think that would be a better choice. And they've compared, there was a multiple analysis on such complex cases, and they've shown that the results are comparable. That is what the recent JAC, it has been published. And therefore, a drug-coated balloon, even if it is the L6 ostium, because L6 ostium, even if we stent with imaging, however carefully, within 1 year, the risk of reocclusion is almost 50%. That is what, even if we do it very perfectly, that is the actual thing they are saying, even in the ESC. So I would like to put in here that if necessary, a DCB for the L6 and
Definitely.
with the
Yes, we need to incorporate it more and more, particularly for bifurcations, simplifying bifurcations. Definitely a great point.
yeah, and the recent article, it has also shown that at bifurcations, it increases the ostial size on later, even
Yes.
not immediately. When we review such patients later, the ostium, the bifurcation at the ostium level, it actually, there is a very good remodeling, and it looks better on
Even
future
if you use a DCB in the main vessel, in follow-up, they found that the side branch diameter was increased, right?
increase.
So very
Yes, yes.
recently in some ESC meeting, I
Yes,
think.
yes, yes, yes.
Good
Basically,
remodeling. Yeah.
it was it's always a great idea today in the era of DCBs,
Yeah.
where we are using more and more. Although we don't have, very large amount of data for de novo large vessels, but yes, a lot of people are now using it in bifurcation, and especially after the DCB BIF trial, where they used it in bifurcations to see. But then that was not a left main scenario. And the importance in a left main is, see, there are always both sides. One is that when you are doing a DCB, even a DCB can produce a dissection. Second thing is that if you get away with the DCB, I particularly like to use DCB when I have imaging on the table. Then I know the amount of dissection that I have, and I know that it is safe for me to just DCB it and come out. Second thing is that the points which were raised that DCB causes a late lumen enlargement. There's also positive remodeling. And of course, you can de-escalate your antiplatelet therapy lesser because you have less metal over there. So all those things, and the vasomotor function of the vessel is well maintained. All those things are very valid points. But again, when we are going single stent provisional, and then there's always also the question of fenestration of the LCX ostium because of the struts which may be left there. And then when you're taking a balloon and doing a kissing, there's always a chance that you may end up dissecting the circumflex ostium and going into a two-stent strategy. So many of these things we keep discussing, and ultimately it's decided on the table by the operator and how sick is your patient. Now we'll take comments from Dr. Ritu Bhatia.
Hi. So, Seema, in addition to what previous panelists and chairpersons have said, I think the access to CERT was not difficult in your case at all. I mean, it was a good large vessel and the angle was very, very favorable. In case you had any problem, you could easily access it very fast. You know, at times, difficult angulation, difficult access, you can think of upfront two stents. So that was probably in favor of single. Second, did I see a little dissection in the RCA also? I mean, did you see a little haziness on the RCA?
Yeah, in the mid RCA.
You felt in the mid RCA there was a flap?
Yes, ma'am. Yes, yes. But because it was non-obstructive, we thought that even, I don't know what it was, imaging would have shown whether it was a spontaneous coronary dissection.
It
But
looked
still,
like that.
Yeah, it looked like that. There was a mild feeling kind of a streak there. Could be, but only imaging was the only way to know definitively what is the anatomy inside. That could be the culprit lesion. We did not know.
I thought so. But otherwise, so well done. And I mean, it was commendable. And even the presentation, you are a good presenter. We all know that. And it's fabulous. Enjoyed every minute of it. Congratulations.
Thank you.
Thank you, Dr. Ritu. Now we'll take comments from Dr. Ruchi Gupta. Dr. Ruchi?
Yeah. Hi, Seema, congratulations.
Thank you.
Your presentation was excellent, and I think everybody has said a lot about it. So I'll just say if I had been there at your position, maybe I would have chosen a provisional stenting first.
Yes.
And then, of course, if needed, we would have gone for a bifurcation.
Yes, ma'am.
But otherwise, whatever you've done, it's commendable, especially in absence of imaging. So
Thank
very
you.
well done, case. Congratulations.
I think, Dr. Seema, there's been um, wonderful appreciation for a nicely done case. Of course, we all have different views as to how we would have dealt with it. As we get more and more experienced and as we get more and more senior in this profession, I believe that all of us believe that less is more. And especially after the EBC document, we all feel that let's start with provisional and follow up the case as it goes. But many a time we understand that the patient may be sick, that you upfront wanted the patient to be safe. You didn't have MCS on site. Now, there is a last question for you there's a webinar chat question for you, Dr. Seema. So somebody's written, good evening, everybody. Patient presented, Dr. Asha Murthy actually has asked this question. A patient presented with heart failure reduced EF. Was medical treatment optimized before the procedure since it was an evolved MI?
Yes, ma'am. Yes, but he was also having ongoing chest. He was having chest pain since 5 to 6 days. Drops were highly elevated, and he was having severe. And ma'am, this same patient in January 23, he had a normal echo, negative stress test, and then for 2 years he had come to me for the very first time, but he had undergone. So this was clearly a very new event and a new LV dysfunction, and of course, heart failure management not optimized. But he was not kind of ischemic DCMP where, there are questions whether to revasc, only medical management heart failure. He was clearly an ACS with highly elevated drops and ongoing chest pain along with LV dysfunction. So yes, heart failure medications were also optimized, and he was taken for revascularization.
Thank you, Dr. Seema. We'll take final comments from Dr. Jyotsna, madam. I can see her on the panel before we move to our next case. Jyotsna, ma'am.
Yes, madam. As everyone's appreciation, I will join along with them to appreciate Dr. Shima. As everyone says, I also say it's the provisional stenting. But the major thing is actually when you have severe LV dysfunction, provisional stenting would have been made it your life much more easier than thinking of the mini crush. That is the first one. And second one is whenever there is an LV dysfunction, we forgot to see the LV EDPs and the pulmonary capillary pressure. So, which is a very simple procedure which has to be included. If you don't have some catheterization labs, doesn't even have a capillary wedge pressure balloon itself. So at least you can see the LVDP. Please make it a mandatory in all LV dysfunctions to see the LVDP to make you take a decision further whether you can go for a complex or not. Third one is I don't consider this as a mini crush because there is a distal left main and almost you covered the distal left main whole of the disease and then you crushed it. So it is beyond a mini crush. That's what I feel. The views what
Protection was little more.
1 minute. Let me finish it off this
Okay.
thing so that
Yes.
you can. And the fourth one is when the patient had an episode of a CVA 2013, it is also mandatory, even though it is bold. Now the incidence of the CVA incidence comes down, but his carotid disease is known to determine one of your features. So you should have been done carotid Doppler also before taking this case. And the fifth last comment I wanted is all the scoring systems for the side branch occlusion are there for us to classify that really should we go or not. So none of the criteria is persisting. So imaginary total occlusion of the L6 in this case is less than the 2%. So we have to take that chance before going for it. Thank you. Excellent case.
Thank you, ma'am. Yes. Ma'am,
Yes, Dr. Siva, you want to say something?
I mean, madam wanted to say that the circumflex stent protruded little too much inside
Yes.
left knee. Yeah.
That is true.
Yeah.
It was a little, so when we are doing mini crush, that amount of protection is a little too much.
Little too.
So you see, the more you protrude it into it, the more will be the metal burden. And at left main, you don't want a stent thrombosis or a restenosis.
Yes.
So the protrusion was a bit more than what we do for mini crush.
Right. Agreed, ma'am.
So actually, many a times, if your protrusion goes beyond what you do for mini crush, then you will have to convert it into a different procedure rather than crushing it.
You have to convert it into a mini culotte. Yes, ma'am. Yes.
So I think those were great comments by Dr. Jyotsna, and the points are very well taken by the entire panel. We'll move to our next speaker of the evening. Dr. Madhumati Panja has just joined. She's consultant interventional cardiologist at BM Birla Hospital, Calcutta. She's going to present a very interesting case of IVUS-guided PCI in a case of in-stent restenosis. Over to you, Dr. Madhu. We can see your screen.
Yes,
Can you-
ma'am. Yes, ma'am. Yes. Thank you, ma'am. Good evening, everyone, respective teachers and my dear colleagues. I'm sorry, I've got a bad cough. Today, I'm going to present a case of, it's a IVUS-guided PCI in a case of instant restenosis. So this is a short history about the patient. 1 second. You can view me, ma'am. She's a female patient, hypertensive, obese, with risk factors of COPD and dyslipidemia. The patient presented with unstable angina, had difficult in breathing on 14 Feb 2022 after 19 years. The previous intervention was done in 2003 with the help of bare metal stent, one at the proximal LAD and the other at the mid LAD. There was no overlapping done. Subsequently, she presented with ACS in 2011 and diagnosed with ISR and managed by POBA. So this is the angiography findings. We can see the left main is normal. The LAD shows diffuse narrowing with calcification. We can all see there's instant restenosis of both the stents. L6 is dominant and normal. RC is non-dominant. So then these are the angiography findings. LAD with diffuse narrowing with calcification from proximal to mid LAD with ISR of both the stent in LAD. So we proceeded further. Our plan was, the hardwires we selected were a 7 French EBU guide wire was used, a Sion blue wire, cutting balloon Wolverine, a non-compliant balloon, and I used DCB, sirolimus, and this case was done under IVUS, guided PTCA was done. So this is the finding post-CAG. The distal part looks healthy. Tightest part is the mid part. So the lesion was crossed with the help of a Sion blue wire, a new generation cutting balloon, 2.5 into 15 was inflated at 14 atmospheric pressure. So we can see the IVUS finding after using cutting balloon. The lesion was inflated with the help of an NC balloon of 3.15 millimeter. We can see the change in lumen gain from 3.90 millimeter square to 6.6 millimeter square. The lesion was treated with the help of two DCBs, drug-coated balloon. At the distal part was inflated with the help of 2.75 into 40 millimeter DCB, and the proximal part of LAD was inflated with the help of 3 into 35 millimeter DCB, inflated at 14 atmospheric pressure. So this is the final result. Oh, since last 19 years, 2003 to 2022, the patient was doing well with BMS. But in 2011, there was an ISR, which was managed with the help of COBA. Recent development of further ISR in 2022 of both the stent and LED was managed with the help of Wolverine cutting balloon and NC balloon. In a patient with high comorbid condition, it's a female patient, obese, COPD, followed by 2 DCB. So the management of long diffuse ISR, calcified lesion with some degree of calcification at 180 degree is managed in a very simple way. So these are the limitations of drug-eluting stents: vascular inflammation, hypersensitivity to metal polymers leading to acute stent thrombosis, unequal drug distribution, late occurrence of new atherosclerosis and stent thrombosis. It hampers future CABG options also. Late lumen enlargement and restoration of vasomotor function, both compromised by the permanent metallic cage. Long-term requirement of DAPT. So DCB, it's a class 1A ESC recommendation for DCB and ISR. So what are the indications of DCBs? What are the approved indications in ISR? Small vessel disease and bifurcation lesions. And the others are in tortuous vessel, in de novo lesions, in diffuse long segment disease with calcified lesions, in acute coronary syndrome, and in high bleeding risk patients. Thank you so much.
Thank you, Dr. Madhumanti. It was a very nice presentation of an imaging guided treatment of an in-stent restenosis using a DCB, which is now a class 1 indication. The house is now open for comments and questions. We'll start with our chairpersons.
Was there much, there was not much neointimal proliferation, right?
Ma'am, it was basically a fibrocalcific lesion.
Okay.
Long diffuse calcific lesion was there. So I used Wolverine cutting balloon. Then I used NC followed by DCB.
What did the patient present with?
Unstable angina, ma'am, with chest pain.
Okay, okay.
Ejection fraction was normal. Hemoglobin was normal. She's a typical obese patient, elderly patient with COPD and hypertension.
Did you consider doing an FFR? Was it significant? That was because I didn't find that much neointimal proliferation. Definitely, that was in the era of 2003. The stents were totally undersized. And we see this quite commonly, and we see, some haziness, but was it really functionally significant? That's my question. Right. Any more, others? What
I think I also feel the same way like how Dr. Sujata. In fact, in few cases I saw where the stent size was undersized. So the means beyond the stent at the wall, vascular wall, also we saw some calcifications. And could it be that it is beyond the stent, like outside the stent also there was some fibrocalcific, lesions are there. So as if the intraluminal means physiology was not much, means not less than 0.8 as we see normally. So we could have left it out, or you have done very well with the cutting balloon and with this. Maybe if it is beyond the stent, could it be IVL which could have improved the size of the stent, and you could have gone the stent into wall to wall afterwards without using DCB, just by cutting balloon and using a NC balloon or a high pressure balloon by putting the stent onto the wall. That could be one of the ways if it was positive, of course, physiology. Yeah.
Dr. Jyotsna, madam?
Yeah, I don't know her center. Otherwise, she has done an excellent job. But a few comments about IBUS versus obesity in this case. As we already know that even neoatherosclerosis with the latest has come of HD IBUS also is able to tell the composition of the plaque, but definitely obesity is much better in these type of the cases when compared to the IBUS, especially when the stent struts will obstruct beyond the stent strut presence of the calcium in an IBUS, which can be the seen very well with an obesity. So then we can have the much better, if you of course have the limitation, and if there is a limitation for then using the contrast nowadays with even the saline also they're doing. So then probably IBUS may be the much better option to do it. But as you said, diffuse dilatation, balloon dilatations, either with the DEB or if you don't have the DEB with a NC balloons is going to be a much better option than covering with the stent. That is definite.
Yeah. Yeah, that we totally appreciate. But I was looking, so many times you'll be seeing these stents, of the past, which are there inside the arteries, which are, are under expanded and all.
Yes,
They
ma'am.
are confused whether they are really causing something. And especially, as I said, without much neointimal proliferation. And you see, sometimes, luckily, the stent size is very small compared to the vessel, but there's no neointimal
Yes, ma'am.
proliferation, and then you are you generally don't try to do anything, right?
Yes.
Yeah.
So in that situation, Dr. Sujata, how about going high pressure NC balloon or an OPN
Yeah,
NC?
I would have done an FFR. If it was positive, I would have just proceeded just like Madhumati with high pressure balloons, try to expand the stent to its size before deploying the thing. Yeah,
Dr.
and
Manjula?
I forgot to see how post-stent, all these DCB and post-cutting and NC, whether she got good MSAs,
Yes,
good
ma'am.
MLA. Did you get a good MLA?
Yes, ma'am. Yes, ma'am. Yes, ma'am. I got.
Compared to the previous?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Because otherwise, again, you'll be in the same.
Yes, ma'am.
Any more comments, Dr. Majella?
It was a great case, and I would like to congratulate Dr. Madhavanti. The way she had done it was really appreciated. No comments.
So if there are no further comments, we will conclude the meeting. Thank you, Dr. Panja and Dr. Naxin, for the wonderful presentations today. Both were very interesting cases. Left me in bifurcation every time we discuss it, but every time it remains interesting about and how to approach it, the various ways to approach it. And of course, now with the increasing use of DCBs and with the increasing use of imaging, so an imaging guided use of DCB in an ISR situation, which is now a class 1 indication. So great cases, and thank you to both the speakers, to all the chairpersons and the panelists. Good night, everybody.